Today we will discuss Guillain-Barré syndrome. The Guillain-Barré syndrome is a post-infectious peripheral demyelinating neuropathy of an unknown cause. In this disease, the immune system destroys the Schwann cell, which lead to the motor and sensory deficit. There are four variants of the Guillain-Barré syndrome. The first one is an acute inflammatory demyelinating polyneuropathy. It is a most common variant. The second one is an acute motor axonal neuropathy. In this, the patient present with a motor symptom and there will be a no sensory feature. The third one is an acute motor and sensory axonal neuropathy. In this variant, there will be a more sensory feature. The fourth one is a Miller-Fisher syndrome. In Miller-Fisher syndrome, there will be a three classical feature. The first one is an ophthalmoplegia, the second one is ataxia, and the third one is an areflexia. When we talk about the Guillain-Barré syndrome, we actually talk about this variant, the acute inflammatory demyelinating polyneuropathy. So we will discuss this variant in detail now. How a patient of the Guillain-Barré syndrome will present clinically. Clinically, the patient will present with a history of infection, most commonly the upper respiratory tract infection caused by cytomegalovirus or the Epstein-Barr virus or the gastrointestinal infection caused by Campylobacter jejuni, which most commonly cause a bloody diarrhea. After this infection, when the 3 weeks are passed, the patient will present with ascending paralysis. By the ascending paralysis, we mean that the paralysis will begin in legs and it will spread ascendingly. Other than this ascending paralysis, the patient will also develop loss of deep tendon reflex called as areflexia along with hypotonia and decreased muscle power. Apart from this motor symptom, the patient also develop a sensory symptoms, but the sensory symptoms are usually mild. Apart from that, the patient also develop facial palsy. The facial palsy is bilateral in 50% of cases and unilateral in 25% of cases. And the most deadly involvement of the Guillain-Barré syndrome is the respiratory muscle involvement. It involves the respiratory muscle in about 20% of cases and it is usually fatal. Other than this, the patient can also develop autonomic dysfunction. The autonomic dysfunction occur in more than 70% of cases and it includes both sympathetic and parasympathetic dysfunction. It includes tachycardia, urinary retention, hyper or hypotension, arrhythmia, ileus and the loss of sweating. The question arises that why all of these symptoms develop in Guillain-Barré syndrome. These symptoms develop because there is a demyelination. How this demyelination develop? When a patient develop infection, our immune system develop antibody. This antibody, instead of attacking the virus and bacteria, it start attacking the Schwann cell. The Schwann cell are the peripheral demyelinating cell. So when it attack the Schwann cell, it destroy the Schwann cell and which lead to a demyelination. So all of these clinical symptoms are a result of the demyelination of a peripheral nerve. Now come toward the diagnosis of the Guillain-Barré syndrome. The diagnosis is usually clinically. We diagnose the case on a clinical ground when a patient presents with ascending paralysis with a history of infection. But we need some supporting evidence. For supporting evidence, we can perform a CSF study. The CSF will show albuminocytological dissociation. What is meant by this albuminocytological dissociation? It means that there will be an elevated protein level in a background of a normal cell count. Usually the protein, predominantly albumin, will be high, usually greater than 1000 milligram, and the lymphocyte will be raised or normal, usually less than 20 lymphocyte per millimeter square. If the lymphocyte is greater than 50, it is very unlikely that the patient is suffering from a Guillain-Barré syndrome. Other than this CSF study, we can perform a nerve conduction study. The nerve conduction study will show the conduction block or the slow conduction. Other than these, we can also perform a respiratory function test to rule out the respiratory failure. So in short, we diagnose the Guillain-Barré syndrome on a basis of a triad. The triad include the acute symmetrical ascending paralysis of limb, Areflexia and the albuminocytological dissociation. So whenever these three criteria are fulfilled, we can make a diagnosis of a Guillain-Barré syndrome. So it was all about the diagnosis. Now let's discuss the treatment of the Guillain-Barré syndrome. The patient of a GBS should be treated in ICU along with the regular monitoring of her respiratory functions, because the GBS involve a respiratory muscle in about 20% of her cases, and a patient can die of a respiratory failure. Other than this, the drug of choice or the first line treatment for the GBS is a high dose intravenous gamma globulin. It should be given in a dose of about 400 mg per kg per day for 5 days. It is very helpful if given within the 14 days. Other than this, we can also perform a plasma exchange. The plasma exchange should ideally be performed within a 14 days, and it is equally effective as a high dose IVIG. Apart from this, we can also consider a plasmapheresis. All of these three are the treatment of a GBS. Remember that never give a steroid in a patient with a GBS, because the steroid have no shown prove a beneficial value, but sometimes it can cause a worsening of a GBS symptom. So avoid steroid in a GBS and consider the rest of the three options for a GBS. If a patient is diagnosed and treated early, the GBS show good prognosis. About 80% of our cases show full recovery within 3 to 6 months. Sometimes if there is an axonal damage, the recovery can take about 6 to 18 months, but 80% of the patient will recover. Other than full recovery, the 10% of a patient will present with a residual disability, while the 3 to 5% of a patient can die due to a GBS. So it was all about the Guillain-Barré syndrome. If there is still any question, you guys can ask, and stay tuned for more update.